I don't take other people's time. So just first of all, welcome to this webinar. We're really excited to finally launch this report, and we'll be getting into the nitty-gritty about it in this webinar. As an introduction, my name is Ruby Lawler. I'm the Executive Director of Youth Rise. And I'm really excited to be moderating this webinar and hearing from the amazing panelists. So before we begin, I just want to get a few quick housekeeping rules. We're going to keep the mics muted just so that the panelists and the presenters can be heard really clearly. And if you do unmute, we will be muting you again. Rebe is helping with all of that technical stuff, but we do want to hear from you. So if you have any comments or questions, please leave them in the chat. I will be taking note throughout the webinar of anything that you have to say that we can then come back to in the Q&A section at the end of the webinar. Also, if you have any technical issues you're not able to hear correctly or anything, please use the chat and let us know. Maybe one of us is on mute and we don't realize, so maybe it's on our end. So just make sure to keep active in the chat. This is an ongoing, engaging webinar. So the people we have speaking today are Elena, Teresa, Patricia, and Vincentius. And then we have the fantastic Rebecca Calzada also supporting with technical side of things, and who will be taking part also in the Spanish version of this webinar launch tomorrow. So a bit of an introduction about Youth Rise. For those who aren't so aware of us, we are an international network of young people advocating for drug policy reform and for the human rights of young people who use drugs and all young people affected by punitive drug policies. We have an international working group, and this is the network that we speak of. And a few of the members here today are from this international working group. This international working group is made up of young people who use drugs, young experts, young harm reduction practitioners, young activists, young researchers, and it's really the core of our organization. The international working group members inform us about the realities of young people who use drugs in their local and national contexts, and the availability and accessibility of harm reduction services, the impact the policies have on them, whether it's drug policies, harm reduction policies, human rights related policies, gender related policies. We also work with our international working group members to make sure that they are meaningfully engaged in policy processes and decision making spaces that affect them. So that's at multiple levels: international, regional, local. And we also support our membership through capacity building and through resources when we have them available in terms of funding, small grants, mentorship, and our international working group members are really core of the work that we do and inform the work that we should be focusing on, including work like this report today. So in 2023, we created an advocacy strategy, and that's where it really launched this process that we're coming to you with today. This advocacy strategy complemented the kind of broader organizational strategy we already had and created 4 work pillars or goals that we kind of consolidated our work under. So one of them is the full spectrum harm reduction work pillar advocacy goal, and that's what we're going to be talking about today under this program. Rebecca has shared in the chat our advocacy strategies. If we want to have a look at the rest of the things we work on, please have a look at that. And then last year, we developed a statement on full spectrum harm reduction. So this was to ground the work that we were already doing on this topic, but to really put a kind of a statement on what it is exactly that we are focusing on when it comes to full spectrum harm reduction, what we mean when we say this. And it gives a very important nod to those who've come before us in the harm reduction drug policy world, who lay the groundwork for the harm reduction movement that we are in now. And many of us attending this webinar are also taking part in. So coming to the purpose of this webinar, the report itself was the result of a survey that was conducted in November, December last year, which captured the experiences and perspectives of harm reduction practitioners, peers, young people who use drugs, young researchers, and other relevant stakeholders across many regions in the global north and the global south. We wanted to make sure that this was quite a comprehensive report and survey. And the survey then resulted in this report, which you'll learn about today, and it gathers the qualitative and quantitative insights into what full spectrum harm reduction looks like in different places in the whole world. And this is the official launch of it. So we're really excited to have you here today, and then also for the Spanish version of this webinar tomorrow, but there'll be other speakers presenting from their perspectives. And I don't want to take up too much time, so I'm going to hand us over to the first two presenters, which will be Elena and Teresa. So a bit of a background, Elena Keller is a recent graduate of public health from Lund University in Sweden, who has a background in working in harm reduction and case management services in North Carolina in the United States. And Teresa Castro is involved and has been involved in harm reduction since she was 18 and started volunteering in nightlife settings. Currently, she is a social worker, activist, peer worker, and a person who uses drugs and experienced in social intervention as a case manager and project coordinator. And she works directly with marginalized communities such as people who use drugs, sex workers, migrants, people experiencing homelessness, amongst others. And she's a peer collaborator at Cosmicare, which is a harm reduction NGO that provides peer-based services. So I'm going to hand over to you guys to present the key findings of this report, and then we're going to be coming later to a panel discussion with Patricia and Asfian to talk about some perspectives from their regions. And thank you. Over to you, Elena and Teresa. I'll share my screen.
Hello, everyone. Can you hear me properly? Yeah, amazing. So thank you so much for coming. I'm going to present together with Elena the key findings of our report. I'm just waiting to, to see the screen share. Amazing. So this report had many focus areas. And in this presentation, we tried to include sentences and perspectives of those who participated in the survey that shaped the report, both from Global North and Global South. Regarding the definition of harm reduction, full spectrum harm reduction, I decided to include here two sentences from the survey, one from Global North and one from the Global South, that I think they explain very well what this concept is. So we have here that full spectrum harm reduction is a comprehensive approach that includes all substances, any type of use, and any individual profile, recognizing that it is possible to design interventions in every stage of the spectrum. It emphasizes the non-pathologization of drug use and acknowledges the structural factors that exacerbate or mitigate risks or benefits associated with substance use. So it's a comprehensive, holistic framework designed to address and advocate for the needs, desires, challenges, choices, and priorities of all people who use drugs in every context. This contrasts a little bit with the typical and traditional harm reduction, which is very focused on specific profile and specific the user of opioids and an older, usually a man. And here we try to, in full spectrum harm reduction, we try to include all people who use drugs, as harm reduction actually should be as a definition for starters. You can pass to the next slide.
Okay, I'm going to talk about the background. I assume you guys can all hear me, if not, just interrupt. So yeah, I think it is now clear what the aim of the survey was, just to gather insights from different stakeholders, to understand how they understand and implement full spectrum harm reduction and the challenges and the innovations that they see within their contexts. So the survey was open from November 29th through December 15th of 2024. It was promoted through Youth Rise's social media channels, but also through our international working group members. The survey questions themselves centered around five main areas: the definition of full spectrum harm reduction, innovative practices, structural and policy impacts, inclusivity challenges for key populations, and the resources and support needs to strengthen harm reduction globally. So you can go to the next slide. So about some of the demographic variables we examined, we really looked at three main aspects. We looked at the country and the city where respondents were operating, their organizational or institutional affiliations, and then their primary roles within harm reduction. By analyzing these variables and then later connecting them with the qualitative responses, we can begin to identify patterns and relationships across different contexts. It's important to note, though, that this data is not significantly representative of entire countries or regions. Instead, it provides a broad overview of perspectives from those who responded. So in total, we had 59 surveys that were completed. 40 of these were in English, 16 in Spanish, and 3 in Portuguese. The non-English ones were translated for analysis. And in terms of representation, roughly 61% of respondents were based in the global south and 39% from the global north. It's also interesting to highlight that many people within harm reduction take on multiple roles at the same time. So when we delivered this survey, we actually asked people to tick off their primary roles within harm reduction, but this was a multiple response answer. So the numbers you see obviously surpassed the total number of participants who took part in the survey. We can see that on average, people held roughly two roles within harm reduction, and it's worth noting that many actually do identify themselves as young people who use drugs, which is really nice for the purposes of this presentation and like to understand their perspectives. But that also likely means that they're holding many different roles within that, whether it be as a practitioner or something else. So now you can move on to the methodology section. Lovely. So to better understand how full spectrum harm reduction is defined and implemented, we use both qualitative and quantitative methods. For the qualitative, the survey included several open-ended questions, including one that asked participants to identify or to define what full spectrum harm reduction means to them. So we then coded and analyzed these, and from this process, 7 main themes emerged, and we're going to focus on 4 of them during this presentation because we felt that those were sort of the most prominent ones. On the quantitative side, we looked at responses to the structured survey questions that basically asked which harm reduction strategies and broader social supports should be a part of full spectrum harm reduction framework. These included some of the things that you see here, like drug tracking services, decriminalization, stigma reduction campaigns, etc. I'm not going to go into the integrated analysis that combines the quantitative and qualitative findings, but for context, the deeper level of analysis really showed how the qualitative perspectives aligned with the quantitative priorities in building out this comprehensive framework. It is interesting to know that both in respondents from the Global South and Global North, the most selected aspects were that of access to healthcare and mental health services, social services, drug education and recreational settings. So there's a lot of overlap. And interestingly, the least selected from both are also environmental impacts of the war on drugs. So now we can move on to the next slide. So these are, I'm going to present now 2 of the main themes that kind of came out of this survey from the qualitative analysis. So one of these is what we considered inclusive approach. And what that means is being truly context specific, recognizing that people use many different types of substances through different routes and that each of those requires tailored responses. As one of our respondents mentions, it also means providing integrated, collaborated and person-centered, not drug-centered care that considers the needs and priorities of people who use drugs in all stages of their relationship with drugs. It also means taking an intersectional perspective, understanding how overlapping identities, such as being young, LGBTQ+, a migrant, living with disabilities, all of these shape the overlapping and compounding risks that people face and their access to support. Inclusivity also, of course, means that programs are not designed just for the community, but also with them. And this kind of bleeds into the agency and empowerment a bit as well, where respondents also emphasize that people who use drugs must be central to the design, implementation, and the evaluation of services. This includes moving away from this top-down service delivery into a more peer-led initiatives that reflect the realities of the communities themselves. Within agency and empowerment, it's also recognized that marginalized groups must be treated as key stakeholders and not afterthoughts. Again, that their leadership and their active participation are really critical for these interventions to succeed. Respondents also noted that empowerment comes from access to accurate information and from tools that allow people to make informed, autonomous decisions. So, for example, naloxone distribution was widely cited across regions as being a key factor in full spectrum harm reduction, both from the global north and the global south. And we believe that's because it enables peers and communities to be really directly involved in these life-saving measures. Similarly, drug checking services, overdose prevention programs, all of these were highlighted as really empowering strategies that can shift the balance of power, allowing communities to take more control over their own safety and well-being. So I think that this theme of agency and empowerment really does reflect a strong consensus among respondents that harm reduction is most effective when it's led by and for people who use drugs. Next slide, and this one is you, Teresa.
These themes, these two themes, innovations and advocacy, and structural and contextual realities. I feel all of the themes that came out of the report, they all interconnect with each other. So regarding the innovations and advocacy, this theme points out the need to evolve in response to the new realities that exist in drug use, to address and adapt to those realities, to those needs, to those new desires of people who use drugs, to be flexible, to be creative, like Elena also already mentioned, and we will mention again, the need to actually engage people who use drugs in the design, in the implementation, in the evaluation of all the interventions and the policies that impact them. Also, regarding the advocacy, this advocacy must drive systemic change to challenge structural barriers, which is also and also recognize pleasure and enjoyment. Regarding this specific topic, I will not get into it right now because I will talk a little bit more about it in the end. And I put here a quote because I'm from Portugal, and we have a drug policy that is seen as very new and innovative. It's a model, our drug policy, the Portuguese model. And I found it very interesting, this sentence here that shows how we still need much more than that, how our criminalization at least is still lacking a lot of innovative response. And regarding the structural and contextual realities, I wanted to point out the social determinants of health, which are a very important topic to me as a social worker. And also because they impact health and health outcomes much more than many health-related factors. So the importance of addressing these determinants in order to improve people's health. And this also changes a lot from context to context. The fact that you were born in a specific context affects much more your health than many other health-related factors. So also violence and institutional violence, which is something that also as a social worker in my work, I could unfortunately see every day regarding our service users. The need for cultural adaptations to each context, stigma and discrimination, and how this impacts people who use drugs, and is perpetuated through language. So how words matter. The power imbalances that exist, and also the punitive drug policies that also affect the availability of harm reduction services and funding. And all of these are structural and contextual realities that impact people who use drugs' lives, and were very mentioned many times throughout the survey and the reports. We can go to the next slide. Then we tried together some strategies and interventions that the respondents considered to be part of full spectrum harm reduction. And I put some here. We have in Italy, for example, integrated HIV testing with drug checking services. In Portugal, there's a drug and alcohol consumption room that's integrated into a shelter. There's also a group project managed for women and non-binary people who use drugs. In the USA, there's a team of doulas that support and house pregnant people. Mexico has a drug consumption room for people, for women who use drugs. So all of these interventions target communities or methods of use or all aspects that are not usually integrated into traditional harm reduction. The fact of the necessity of using digital tools and social media more and more it was also mentioned a lot of times. Also, an intervention, an online intervention called the toolbox was mentioned by one of the respondents, which is an online intervention. And also something I found very interesting was the peer-to-peer work done in forums, which is a very informal intervention, but it's very relevant to, especially I would say to young people. Regarding the challenges, gaps, and needs, we found structural factors as policies, infrastructure, stigma, obviously funding issues. It was one of the most mentioned topics, the funding issue. I think most respondents refer to funding issues. Also, the punitive drug policies that, as I said previously, they impact the accessibility of the harm reduction interventions, and the lack of services for specific populations. So this obviously impacts the implementation of full spectrum harm reduction interventions because they should be universal and target everyone. I would also wanted to mention that 9 people they talked about the need for legalization regulation. So not only decriminalization, these people actually refer to legalization and or regulation. And I found it interesting that 3 were from countries that already decriminalized drug use. So this made me reflect on if decriminalization is enough or if we need something more. If it's a step for something else. You can go to the next slide. So as I said previously, I'm going to talk a little bit about something that we found it was very interesting that was mentioned by 4 people in the survey, which is the role of pleasure and how drug use is seen as a negative thing, is pathologized, and how this happens with this specific behavior using drugs, and it does not happen with sex. It does not happen with radical sports. You don't have sexual harm reduction. You have sex education. You have driving lessons. Only regarding drugs, you have this harm reduction concept. So I wanted to explore a little bit the importance of shifting from reducing harm and being only a reactive intervention and only aimed at avoiding negative outcomes to actually supporting people in pursuing positive experiences, increase the well-being, be a proactive intervention, and improve quality of life for people who use drugs. And I think these types of interventions are the ones that actually speak to people and are appealing to people and will make people actually access services because the services are providing them with something that connects with their reality. So I put this image here that about the hard to reach groups, hard to reach services, and I added the services that I designed for people, not with people, and that it reflects institutional priorities and not people's priorities. And I have some sentences here that I found interesting, but regarding pleasure and the importance of pleasure. You can go to the next slide. So here I wanted just to reflect a little bit of why this new term is needed. why harm reduction in itself is not inclusive enough, because it should be. So harm reduction was born in a crisis context of emergency, urgency. So to prevent that, to prevent HIV, hepatitis C, um, and this term, which can be sometimes seen as a little bit negative, focused on harms and not on on pleasures. Um, in, I was reflecting on why is it why was this term chosen. So uh, what I found was that it was to accentuate the fact that these harms are caused or amplified by drug policy. Um, Also for funding and political reasons, because it's not well seen that people use drugs for enjoyment. So this will not be something that it's not a priority for governments, not a priority for donors. Um, I think it would be much harder to defend a different type of concept, more positive regarding drug use, or even more neutral. Um, this neglects the broader context. It's very medicalized. Harm reduction is a very medicalized field, and I feel as a social worker that it ignores the social determinants of health many times, and this um, makes it very hard to implement full spectrum harm reduction, because if we only focus on the biomedical aspects, we are not uh, addressing all the structural factors that we should. So, and we see health outcomes as a consequence of individual choices, which they aren't. They are a consequence of the whole structural and broader context. Uh, so, um, and here I put three questions. Uh, if this full spectrum harm reduction is putting an old concept harm reduction into practice, if it's an evolution or it's just going back to the basics of harm reduction, if it's an expansion or reaffirming the real mission of harm reduction. It's just some thoughts that I wanted to leave here. You can go to the next slide.
Okay, so just to wrap up, one of the sections in the survey was about recommendations, or in the report was about recommendations and conclusions, and we just kind of wanted to highlight the ones that we reported on. So first, as we know, funding for harm reduction is chronically, underfunded, and programs are often relying on short-term grants. So, to really be effective, there needs to be sustained and more flexible resources that don't just cover the basic needs and services, but also support staff and infrastructure and programs that address these broader issues that we've been mentioning. The second is inclusivity. Harm reduction has to meet people where they are, recognizing the specific needs of women, LGBTQ+, migrants, unhoused people, indigenous communities and young people, and more. These groups aren't just service recipients, they should actively be involved in shaping the programs that affect them. The third was the global knowledge exchange. So a lot of innovative harm reduction practices, really like a lot of innovation comes from under-resourced communities that we can learn from. And so by sharing these lessons across regions, we can really adapt successful models in ways that make sense to our local context as well. So really focusing on that knowledge sharing is really crucial. Then we have capacity building. Workers on the ground need ongoing training to engage with people who use drugs in a compassionate and a more person-centered way. This, of course, includes gender responsive, culturally sensitive approaches. And again, these peer-led educations are really central. But along with this, there also needs to be care for the people who are delivering these services, and working with and advocating for people who use drugs. Harm reduction workers face a lot of emotional pressure, burnout, often unfair compensation, things like this. So really prioritizing their mental health to prevent prevent burnout and ensure fair working conditions is really important if we want to these services to be sustainable. And then a lot of this work, of course, is not possible without addressing the structural barriers, which is our last point. So addressing the punitive drug laws and stigma and inequities in housing and healthcare and all these things that really undermine harm reduction is really critical. So yeah, I think that's all we have on the report. So thank you all for listening.
Thank you so much, Elena and Teresa. It was really great to hear from you both, as you both were key authors of the report, and super involved in the survey collection as well. So it's really, I think, interesting to hear it in a succinct way. It's such a comprehensive report, but you guys did a great job at summarizing. And yeah, hopefully maybe we can share those presentation slides with the people in the call, or something like that, so people can have access to them as well. So if anyone has any questions or comments, please do leave them in the chat. We will address them at the end in the Q&A section. But I'm going to move us along now to the panel discussion, and we have Vincentius, Asfian, and Patricia here to take part in this. And they are regional harm reduction workers. They will be reflecting on their local definitions and adaptations of full spectrum harm reduction, the differences between Global South and Global North in terms of the participants' answers, but more broadly in their own experiences. Some main barriers, was you already heard from Elena and Teresa, but kind of delving into them on a more local level, and then some innovative practices from their own context too. So as a way of introduction, to begin, Asfian is a young harm reduction practitioner and a youth researcher from Inti Muda, Indonesia, which is an organization of young key populations and young people living with HIV in Indonesia. And then Patricia Gomez is a 23-year-old harm reduction worker with a degree in social work. She works in a harm reduction community center and a drug consumption room in Portugal. So thank you so much, both of you, for coming. I'm going to get started with our first question, which is, based on your context, which principles of full spectrum harm reduction described in the report we've just presented feel connected to your context, and how do they meet local needs? Maybe Asfian first.
Thank you, Ruby. Hi, everyone. As Ruby has said, I'm Asvian from Indonesia, working actually mainly in the HIV context, but key populations also in harm reductions focus as well. So, in back in last year, developing this report, I think I want to highlight when it comes to the principles in the concept of full spectrum of harm reductions that is really resonate with my country, with Indonesia, is and also how they meet the local context or need is how all those comprehensive and person-centered human reductions is really related and needed in the among young people in Indonesia, because in Indonesia, for context, Indonesia is really country with a full punitive context for drugs, and also it has required rehabilitations when it comes to a lot of drugs. And so when it comes to those when it comes to those the rehabilitation services, it requires only when it comes only health sectors, health aspects. It doesn't resonate with how young people, especially who use drugs, needs when it in the aspect of social, mental health, and etc. And also intersectionality and inclusivity. I think full spectrum of harm reductions already emphasizing when it comes to those age, and also intersectionality, gender, exclusivity. It resonates on how the queer group as well. It resonates on how in Indonesia it doesn't happen. It hasn't happened. It hasn't started yet. And how FSHR, I really emphasizing on this full spectrum of harm reductions really need to be, I would say, like adopt to in Indonesia, and I will really hope those two things be able to not only adopt, because currently Indonesia harm reductions practices and harm reduction interventions is affected by, as already mentioned before, the funding cuts by the Global Fund, the support cutting by the US government. There are a lot of experience and also situations where all those actually all those interventions when it comes to harm reductions is restricted currently. So I really hope those both things be able to, I will say, like a fresh air when it comes to harm reduction started again to raise again in Indonesia. Thank you, Ruby.
Thank you, Asfian. Yeah, I liked what you said there at the end. Well, I liked all of it, but in particular about full spectrum harm reduction being like a fresh air, a breath of fresh air. I think worldwide, given the funding context, it's an incredibly difficult time right now, and it's important that as we fight through this, we continue to center what's super important, which is these life-saving services and more.
Yes, Ruby, can I add like 10 seconds a
Of
bit?
course.
So actually, everyone, I really need your attention. My country is in going is in the process to implement martial law right now in Indonesia. I don't know if you'll know about it. And Indonesia harm reduction practitioner is one of the activists that is working directly with the human rights activists in the streets. So currently, like 3,000 people are getting busted, and currently the president are in ongoing shooting everyone in a lot of cities to implement the martial law. So please pray for us and resonate with the voices. Thank you so much. I know this is different context, but thank you.
No, like we've just learned, it's all intersectional. Of course, it's the same
Yes,
context.
thank you.
Thank you for sharing, Asfian. I'm very sorry, and yeah, prayers are with you. Patricia.
Hi everyone, thank you for having me. I'm Patricia, and responding to your question, there's some in Portugal, there's some principles of alarm reduction that coexist with already what we do. So in harm reduction intervention, we start from the idea that the drug use is just one part of the person's life and does not take away their rights. And this approach also helps fight the stigma and build trust between the people and the services. We also work with we also work with peers, and they have an essential dimension. And also, people use drugs are actively involving in designing, implementing, and evaluating services. And this makes interventions more realistic, effective, and aligned with the actual needs. We also have social determinants of health. As a social work, I know it is impossible to think about drug use in an isolation. So, housing, employment, social networks, and living conditions are deeply connected to drug use and harm. And we cannot address drug use without addressing these broader factors. There are some tailored services existing already, like woman only hour. Like in Morelia, we created a space only for women, and we also have chemsex consultations, but these are very limited and often minimal. And about the legislation, Portugal has discriminalization, which is seen globally as a major achievement. It's a crucial step forward, but it's not enough. There are still major gaps in services, inequality access, and lack of consistent investments.
Thanks, Patricia. Yeah, it's really interesting. I always find it very interesting to hear from those living in contexts where reforms like decriminalization have taken place, and particularly with Portugal, being 20 or more years since that law was adopted, to see what it looks like now. There's obviously, like you said, there's a lot of positives and innovations that have come from this law and enabled by it, but at the same time, there's a certain way that it still needs to go to be able to fully be adopting a full spectrum harm reduction approach. I'm going to bring us to the next question, unless Elena or Teresa, you have anything you want to come in with on that one.
Just maybe also
Sure.
coming from Portugal, I don't have much to add, of course, because it's the same context as Patricia. But yes, she's very lucky to work in a very specific service that really does try to implement post-spectrum harm reduction as much as it can. Unfortunately, that's not the case for the whole country. And yeah, regarding the legislation part, how I find it always find it interesting, and how people mention it a lot as a goal, and we have it, and of course, we are very privileged comparing to a lot of countries. That's undeniable. But how it's not the paradise that people imagine. Not at all. Actually, there are a lot of people that visit Portugal and visit our services and are confused by our lack of services and how we are stagnated in time. Just to add that.
Thank you, Teresa. I think that kind of leads us really well into the next question, which has been partly answered already, but I'll ask it anyway and see if there's anything to add. So, what cultural, social, or political factors do you think influence how harm reduction is understood and implemented in your context? Patricia or Asfian?
I think I can start. Since 2001, Portugal had a culture shaped by the drug discriminalization, and this actually supposedly creates a more favorable political environment for harm reduction. So international, the Portuguese model is a lot celebrated like an example, but internally, the people who working here, see that this reality is more complex than this. We still face a strong social stigma around drug use. I can give you an example. When this drug consumption was created, initially it had a strong opposition from local residents. Uh, but when we temporarily need to close it, the community complained about the visible drug use in the streets and blamed us that this happened because we closed the room. So this kind of illustrates the not in my backyard logic. So people don't want the service, but they also don't want to deal with the consequences of its absence. Drug use in here is often viewed by authorities and governmental as inherently problematic. So this makes it difficult to implement differentiated approaches. And important aspects like pleasure, experimentation, or diverse consumption patterns, especially among young people, are largely ignored. We have some services like Cosmic Care and Be Safe, but they're almost non-existent. We have some options in here in Portugal, like prevention, but is mainly focused on absence. We have visualization and we have treatment with limited diversity in approaches. And as I said before, discriminalization is a privilege and an undeniable step forward, but it cannot seen as our final goals. We have serious underfunding effects, and this affects harm reduction and also treatment services. Innovation is scarce, and the international image of success contrasts with the reality. We have many visits expecting to see the golden model Portuguese, but they actually leave disappointing after seeing the lack of access and resources that we have. Thank you.
I want to
Thank you,
add some.
Patricia. Yes, Asfian, please.
Thank you, Patricia, for saying decriminalization is what did you say? Like a privilege. It's really interesting because in Indonesia, in Southeast Asia, especially, it's really emphasizing on the moral religious framing when it comes to my country, which is pro-dominant Islamic country. I think when it comes to cultural, social, and political factors which shaping harm reductions like understanding, I would say I have two factors. The first one is those the cultural about moral religious framing, which affecting this how the stigma and discriminations implement among the society itself towards the people who use drugs. And the second one about the political aspects here in Indonesia, because it's a full punitive policy. It's a full punitive and also mandatory rehabilitations. All those cases where the police getting those people who use drugs or having this amount of drugs, any kind of drugs, it become in a become a case of extortions of the victims. So it's becoming one of the system where it's it's a you know it's a it's a system where people, well, the police, the country, the government also getting money from it, getting advantage when it comes to money from the victims of this fully punitive policies. And I will say in Indonesia, the harm reduction services itself, we already have opioid substitutions in the clinics, state-owned clinics. We already have sterile needle services in the clinics, but the amount of people who are injecting drugs in Indonesia is decreasing really high. So it's really small amount of people who do that, and the rest of it is using drugs, non-injectable drugs. And that's the problem, because the criminalizations is really high when it comes to Indonesia. The drug using when it comes to the injectable drugs already covered by the government, already covered the issue, already decriminalized when it comes to the needs of the opioid substitutions. But when it comes to other substances, it's still becoming, I think I will perceive it as a field of money for the government, for those political factors as well. That's what happened in Indonesia. Thank you, Ruby.
Thank you, Asfian. And as a bit of a follow-up question, in Indonesia, when what is the response of the political leaders of the government to people using other drugs, non-injecting practices? Is the response just this mandatory rehab? Is there anything available?
The first one is jail. I think minimum is 4 years for certain amount of grams, for certain of amount for certain substances. And also the mandatory rehabilitation itself is problematic, because not every rehab facilities in every city, even I live in its capital in the Jakarta, it's not really good when it comes to like satellite cities in nearby Jakarta. When your questions is, are there any support? No, it's only rehab, and also there are many several like services like social, mental, but it's mainly led by the community, by organizations based, community based organizations, HIV focused based organizations when it comes to harm reduction process, but not by the government.
Yeah, thank you, Asfian. I think that's the case worldwide with harm reduction.
Yes.
I mean, it came from the community originally. The origins of it from the HIV movement has always come from the community, and then some governments managed to bring it into their own state mandated health
Mhm.
services. But like you're saying, like it's so important that full spectrum harm reduction exists because of course, providing the clean needles and the opioid substitution therapy and other services are extremely important for those who need them. But there is many other people who use drugs and are existing and living in contexts like you explained, where it's highly punitive, and that the only services that are available to them are these mandatory treatment centers, which have a range of human rights abuses linked to them as well. So it's really interesting and saddening to hear of the context in Indonesia. I'm going to move to the third question in case there's anything. I'm just pausing in case there's anything else, but no. Okay, third question. So, I'd love to know what are the main structural or institutional barriers faced by local harm reduction initiatives, like you've already mentioned, when trying to implement full spectrum harm reduction, specifically for young people. I've heard a few mentions about young people, so it'd be great to know if there is barriers for young people in comparison to older people who use drugs, and what they are in terms of structural or institutional barriers.
You want to
Alicia,
start?
you want to go first?
Sorry, either of you can go first.
I can
You are
Patricia?
start.
fine. Yeah.
Yes. Yes. So in Portugal, we face a lot of social stigma. It remains very present and keeps young people away from the services, and also manifests as self-stigma. So reinforcing there's an us versus them. Like, for example, a young person who uses cocaine at parties does not identify with self. oh sorry, with someone who smokes crack. So this stigma exists in here. So in 2001, we had a reform. Reform was a step forward, but it does not mean full social exception. Drug policy still maintains punitive and prohibitionist, prohibitionist sanctions exist. Information on substance is lacking, and most prohibition-related problems remain. We have insufficient and non-holistic funding barriers, and this forces organizations to fragment their work into boxes. Like we have funding for women, we have funding for people who use drugs, we have funding for young people. Um, there's also resistance from nightlife promoters. Many refuse harm reduction services in their venues to avoid a knowledge that exists drugs inside. So this results in false health through repressive measures, like there's police searchings and restricted access to bathrooms, for example. Police, they also limit access to water. There are no bottles allowed. The caps are removed from persuaded water, and sometimes we cannot refill the bottles. And also, non-alcoholic drinks are more expensive than alcoholic ones. So this pushes people to drink more alcohol without getting dehydration. So in Portugal, it's actually easier to enter in 1 gram of coke to everywhere than with a bottle of water. So the consequence of this, young people consume hastily in unsafe and energetic spaces, creating preventable harms. There's a huge delay in implementing services. In 2001, it was accepted to create consumption rooms. The first one created was in 2017, for example. And all these barriers make it the full implementation of full spectrum harm reduction for young people extremely difficult.
Thank you, Patricia. And Asfian?
I think when it comes to institutional or structural barriers as well to implement FSHR, is how the FSHR as well is already is a good thing to cover a lot of aspects besides health. But in Indonesia, the health sector itself, the budget even getting cut by the government into the military sections. Even it's like let's say harm reductions or HIV is one of those focus on health which are not populist in Indonesia, which is not something that people are putting their attention to mainly. So when it comes to how we implement this, I think it's really hard. The first one is when it comes to budget. National budget is really layered into a lot of obstacles to be able like adding a lot of aspects, a lot of interventions when it comes to fully acknowledging that harm reductions is not only on health, on rehab, on or like when it comes to opioid substitutions. And the second one is when it comes to implement it, I think it become more difficult because the plan with Indonesia, we yet next year we will implement a new penal code which consists of all every kind of criminal code policies in one centralized policies, the new penal code in 2026. So it becomes a new strategy of advocacy to be able to tackle a new criminalizations, a new policies when it comes to those penal code itself. And also I think funding gaps also experienced by the organizations in the district level, in the city level, to be able to do the advocacy work to the national level. That's for me. That's for me.
Thank you, Asfian. Yeah, it's interesting to hear about the financial side of things in Indonesia with the priorities of the government and the national budget, and how that's going to impact as well, how the new penal code is also going to impact advocacy and having to relearn the advocacy in that regard. Um, Patricia, it was really interesting to hear about how decriminalization has not meant social acceptance and that young people are still being left behind, particularly in regards to maybe not feeling that they're able to access the services that are available, that kind of self-stigma you talked about, and then also the social stigma that exists. Is there any strategies or actions that you've experienced or that you see locally and maybe you're involved in that are trying to overcome these obstacles that young people are facing in accessing harm reduction?
I think the most specific thing is when it comes to there's a coalition on to do the advocacy about the harm reductions policy reform nationally. Currently, my organizations in Timuda and a lot of organizations we are working to tackle the harm reductions. Sorry, the fully punitive policies when it comes to in the context of penal code before it's implemented in the 2026. Currently, there are several meetings, several advocacy, and also research has been done to be able to understand a new regulations on on the criminalization itself. And actually, I would say it's a good process because we have been it has been as I said, there has been several meetings with the House of Representatives to discuss about this. There is some progress when it comes to not implement to adopt our voices, but still we still it's like a gambling to see whether the advocacy, the demand that comes from us be able to adopt and accepted by the government when it comes to the implementation next year. So I remember a lot of interventions like alternative when it comes to harm reductions interventions for young people living with HIV, young people use drugs in the province. But I think for now the most important things, those like a policy umbrella, the law umbrella, is really need to highlight when it comes to hoping for a better harm reductions environment in the next like 5 or 10 years in Indonesia.
Thank you, Asfian. And Patricia?
So in Portugal, to overcome all the challenges that we have, uh, we don't have that much. So, or is it the institutional efforts to maintain services like Cosmic Care or Gato Moraria, or self-organization initiatives? And this is how we get through the challenges.
Ah, I see. Okay. I would be have in your experience with young people when they are trying to access services, where is it that you see that young people access them the most? Would it be in the nightlife settings or is it through peer outreach? How are young people really finding out about services and accessing them locally?
In Portugal?
In Portugal and in Indonesia as well, although I acknowledge it's a challenging circumstance.
Sorry. So in Portugal, we have Cosmic Care that do drug checking and psych care. They have their place, they have their structure, but they also do drug checking and psych care in recreational contexts. Not in everywhere. They do like more in Boom Festival, for example, like big festivals, not in the live nightlife. And sorry, can you repeat the question, please?
About where young people are accessing harm reduction most. If they, with the harm reduction services that are available, where are you seeing young people accessing them? Is it in that kind of nightlife, like you said, with Cosmic Care or festivals? Are you seeing them coming into maybe drug consumption rooms, spaces like this?
Okay. So, harm reduction is not a team that is being talked about among the young people. So, most of the times, when for example, I present Cosmic Care to them, they're like, "Oh, really? This really in Portugal exists a service like that?" And I'm like, "Yes, it does exist a service like that in Portugal." So the there's not much more how do I say information going on between the young people. Only the ones that care about harm reduction mostly.
I think I've seen that a lot since, working in Youth Rise and having this focus on youth-friendly harm reduction. And, it's one thing to be able to advocate for youth-friendly harm reduction. We obviously want that to be existing in the first place, that there's these services that are really accessible to young people. But when there's already services there that young people can access, but maybe aren't super youth-friendly, it's really hard to make young people understand that they're for them as well, that your health matters too, or that there's even services that are there to protect you from possible harms, from drugs, or just lack of knowledge of what you're doing. It's really just still a concept that we're really trying to get out there. And I think something like the full spectrum harm reduction approach is a really great way to show people how they slot into this world of full spectrum harm reduction, this world of caring for each other and caring for yourself. And that can look like so different across different contexts, but they all are inclusive and involved when it comes to full spectrum harm reduction. Um, Asfian, I'm not sure if you had anything to input on that one, on the question about what are the services you see young people accessing the most.
I think the services about that is young people currently accessing the most is through the outreach worker when it comes to accessing the wait, what is last in English, and NSP, needle exchange program. Yeah,
Mhm.
yeah, and also the opioid substitutions as well. Those two, and plus the mental health services, because it's really, so currently it's like a really trend when it comes to among us people who use any kind of drugs, young people, to to discuss about like mental health services, mental health issues in Indonesia. So I will say like those the from the psychologists, through the psychiatrists, and also through the community health workers as well, to help access the NSP and the opioid substitutions through the state-owned clinics. That is the famous one.
Okay, I see. Thank you, Asfian, for sharing. So on this next question, I'd like to know if there's been any particular innovative harm reduction initiative that you've seen implemented in your country. Maybe not implemented right now due to funding or political climates, but if there's an innovative harm reduction initiative in Portugal, in Indonesia, that you've seen out there, maybe it doesn't just address young people, it could be other important populations, but one that you'd like to share from your local context.
So in Portugal, I think we have a little some. We have drug checking and psychcare, like I told. We have also drop-in drug checking. Some night promoters are being available to have nightlife safety spotters, but this is very occasional and residual. But I think we can build something with that. We also have chemsex consultations. Uh, and in here in Moraria, we offer low we provide easy access to buprenorphine by psychiatric consultations.
Great, thank you so much for sharing. I think it's important, like the chemsex movement, I think is a really important one and shows a very intersectional approach to harm reduction. And it's something that I think is a good key example of a full spectrum harm reduction approach for sure. And Asfian, do you have anything to share in terms of any innovative harm reduction, or maybe if not harm reduction, health, young key population health initiative that you've seen that is quite innovative for your context?
I will address how the currently when it comes to a lot of I said earlier, like the budget cutting from several organizations. Like, currently the innovative is on how those harm reduction practices really rely on the HIV response, even though HIV response is really only focused on injectable drugs. But we do it like, okay, when it comes to injectable drugs, it's getting lower, but we still like voicing the advocacy when it comes to non-injectable drugs through the HIV program under the Global Fund, especially because the Global Fund is investing a lot of money to Indonesia. So I think that will be the one that I really like, innovative steps taken by the harm reductions practitioner. Other than that, like when it comes to innovative in the service delivery or innovative in any kind of intervention, I don't have anything to address currently.
No worries. Thank you so much, Asfian, for sharing what you have. Um, so on the final question that I have for you guys as panelists, I'd like to know, and I'd like to know this from Elena and Teresa as well. Why is it important for you to take a full spectrum harm reduction approach in your work, in your daily life, however you want to address it? Anyone can go first. Maybe Patricia?
Okay. So, I think this approach is essential to ensure inclusivity, diversity, and recognizing that people who use drugs are whole human beings with experience, identities, and needs behind drug use, especially. But also, I need full spectrum harm reduction in my parties that I go to, advocate for this because I already went to parties where Cosmic Care with Psycare was and with not. And I feel so much safer. And even my friends asking the questions, oh, what about this dose? Should I do that like this or like this? Well, and I think this is very important because in party contexts, I see pills taking I see pills taking, sorry. I see people taking pills like like I don't how do I express myself? It's unbelievable, like 2 pills of MDMA per night, and they don't even know how many grams it's in that pill. How should we, there's a lot more than just taking the drugs and do not harm ourselves. And I think it's in here that full harm reduction enters. And also investing in this also means dismantling the stigma. It's evaluating pleasure and lived experiences, especially for the young people.
Thank you, Patricia. Asfian, you want to share? Why is
Yes,
it
I
important for you to
think
take in a full spectrum harm reduction approach?
it's important to remind the young people itself, to remind not only the harm reduction practitioners like the general, but especially the younger generations, because I have seen that we have this is so unique because I think we have forgetting about what is the core of harm reductions. It's getting into more specifically on health, but I think full spectrum on harm reductions really help us to more to emphasize it more, how we as a we like a drug user or harm reduction practitioner is a human, not only like have be seen or perceived as a health only, but so it is really important to ground us as well when it comes to the needs and the pathway of advocacy. I hope you understand what I mean. Thank you.
Yes, I do. Thank you so much, Asfian. Teresa?
Yes. So it's very interesting what both said. I think it connects a lot to the findings that we presented. How this medicalized intervention, over medicalized intervention, is not appealing to young people. Um, how this harm, very focused on harms intervention, is not appealing to people. And how, for me, post-spectrum harm reduction is what harm reduction should be on the first place. Unfortunately, it's not, but it is what it should be. It should be inclusive. It should be for everyone, and everyone should feel represented in one service. And for example, I don't feel that I have any service in Portugal that represents me, because they're all very disaggregated, like the drug consumption rooms that are for an old. They are not, but they are. the users are older people. I'm not still represented there. And then there are services for nightlife settings, and I'm not a nightlife user, only nightlife user, or only recreational settings user. So I do not represent it. There's not a place that sees people as a whole. Um, so uh, I think that that's lacking a lot, and that leaves out entire populations of people who use drugs that not to have any service to reach, uh, basically.
Thank you, Teresa, for sharing. Elena?
Yeah, I like what Teresa just said about like full spectrum harm reduction is what we should like that's what it is in essence, harm reduction. I think we've just been using the concept in a way that feels a bit more not one dimensional, but a bit just a bit more broad than the than how we're all thinking about it now. And so I think like when I entered into harm reduction, it was definitely in the context of a place where the opioid epidemic was at a yeah, sort of like an all-time high in my area. And so I think I kind of entered into it with like noticing that people it was very medicalized, I suppose, and I think it really like left out a lot of people's dignity and didn't take into consideration their culture and their personal rights. And so I think just in short, what I appreciate about full spectrum harm reduction is that it really like captures people's full lives and not just like one part of them. And I think that's really what's important is not just to kind of frame it into one issue because it's not. It's all encompassing and I just appreciate like the inclusive and empathetic approach that it takes. So that's why I think it's important to implement.
Thank you, Elena. Yeah, just it was lovely to hear of all of your perspectives on that question, and of course the whole rest of the webinar. I uh, I think a full spectrum harm reduction. I'm going to answer it for myself as well. Um, I think it's so important for the person first aspect of it, which is what harm reduction is in essence. It's a person first approach, person centered approach. But I think over time, because of the medicalization of some of it, the need for funding of others, the higher risk, the lower risk of different administrative routes for drugs and different drug use and different settings in which drugs are used, the whole full spectrum of drugs. Um, it's gotten segregated in ways. And I think that young people are such a breath of fresh air, which was used by Asfian earlier on. Young people are such a breath of fresh air, and we can breathe that life and that kind of community and person-centered approach into harm reduction. It already is there in to a high degree, but I think that it can become fragmented between those young people or those people who are using in nightlife settings and people seeing themselves as an other to other people who use in other settings, or those people who are unhoused living on the streets. I think people can separate themselves from each other, but the full spectrum harm reduction approach really brings us all back together at that person first approach, not drug use or socioeconomic situation approach. That's not the angle you're going in on. You're going in with the person first. And I think that is a really beautiful way to bring people all together, and kind of within the movement, with cross movements, working to end that stigma, that self stigma people hold, but also that external stigma as well. Um, I'm we have 7 minutes left, so I am going to open up to see if there is any questions or comments that people would like to share about what full spectrum harm reduction means to you or in your context. I see Amin has put your hand up, so go ahead, Amin.
Thank you, Ruby. Thank you, everyone, for your interventions. If you allow me for extra time, I'd like to bring the light from my perspective on behalf of the MENA region. I see that there are two major problems here in the MENA region, and I would like to propose recommendations for those issues. The first one is I believe that our countries show official political willingness to act and to align with international recommendations, but they just keep on being repressive and aggressive under the hood. It's like a political schizophrenia. And I think that to tackle this problem, the recognition and the institutionalization of full spectrum harm reduction by stakeholders Big funding societies such as the Global Fund and UN bodies that can exert pressure on countries to adopt one aspect at a time with spectrum harm reduction core principles. We have to bind full spectrum harm reduction with money and funding opportunities. The big funding societies like the Global Fund should fund more projects that aim to create and engage in local and national discussions on drug policy reform. Make that lump a citizen really sharpen its vision to see finally that the punitive laws and restrictive environments never help anyone take off drugs, that they are harmful to their children and beloved ones that might be from the community, that it ensures a dark future for fundamental human rights in their context, which will, if no serious action is taken, extend to other fundamental rights that were taken for granted, until no one is really totally safe and free. So the first problem is really that big gap between what our countries show officially and what they do in the field. Binding money and funding opportunities with full spectrum harm reduction is key in our context. The second problem I see is the lack of education of people who use drugs. You know, I've seen lots of projects based on harm reduction here in Algeria, for example, but all the people working in this project were project managers and administrators that are socially and emotionally unrelated by any way possible to drug use. They never face stigma discrimination and mandatory detention for simple drug possession for personal use. They never can project and advocate for drug policy reform because they believe deep down that depression is the solution. So the capacity building of young people who use drugs is key. Providing them with practical knowledge and skills to run projects, raise funds, monitor and evaluate projects, and strategize actions so that they are ready to work on harm reduction projects when the opportunity shows up. And there's a good example here in the MENA region. Projects based on sexual and reproductive health and rights work better and thrive across our region, mainly targeting MSM and female sex workers, although homosexual acts and sex work are severely punished by law and regarded by religion as a major sin, while drug consumption is nowhere mentioned in holy text as a deviation. Why is that? Because the LGBTQI plus community have strategized and positioned themselves as a sine qua non condition in every single action that's regarding them and never accepted to be an option. They constituted a strong lobby worldwide, even in the most repressive context, and infiltrated the system, making sure the agendas were discussed around the table and not left behind. So, full spectrum harm reductionist practitioners need to do the same. We need to beat institutionals at what they are supposed to do best. We have to be ambitious for political positions and seek for political allies from the community that most probably might exist. We have to reinforce one another and place our agenda, baby steps, even if it's the last item at the bottom list of that important meeting talking about, let's say, education or gender inequalities. We have to pitch it for a few seconds to build a bridge with full spectrum harm reduction and make it through time a priority topic that will need a whole session to discuss. It's not impossible even in our region, in the MENA region. It will take time undoubtedly, but we might not see the result on our living perhaps, but the future generations will. Thank you.
Thank you, Ramin. I'm really, really glad that you shared from the MENA perspective and the full spectrum harm reduction approach in that region or lack of the approach and the steps that are needed to be taken. Really powerful words, I think, to end out the session. So we're going to end it here. Unless there's any other last minute questions or comments. I think not. So I really appreciate everyone who came and anyone who's watching this after the fact on YouTube. Thank you so much. I hope you have a lovely day. Thank you to the panelists and the speakers and presenters. I think you all did an incredible job at sharing the perspectives of full spectrum harm reduction from your regions or lack thereof, what needs to be done, what needs to change, and also the findings from the reports. Really, really well presented. So thank you so much. I learned a lot. Okay. Have a lovely rest of your day. Bye.
Thank you, Ruby. Bye.
Thank you, everyone.
you.
Thank you, Rebecca.